Thanks. Did anybody here know Doug Graham? Yeah, one person. Douglas was the pioneer in addiction medicine in this province of British Columbia. He was a GP, ended up in Victoria, not as a GP. He was the provincial medical advisor, and then he became the coordinator for the Physicians' Health Program for physicians with addictions. But he's an important part of my story. The only time I ever come to this hotel is every October. I hide out here in the dark wee hours of the morning waiting for the race to start, either the half or the full marathon, because it's close to the start line. I don't know if anybody here has done the race, but if you're going to do it, there's a handy spot to hang on. I'm going to talk about recovery medicine. Although I'm passionate about addictions, we're not going to talk about addictions and the neurobiology and we could talk for weeks about addiction, and we're not even going to talk about treatment. And there's a huge amount that we know about treatment. But this is something else. This is what happens after treatment. This is recovery. First of all, my disclosures. I'm retired, so I don't have to accept money from anybody, and I certainly don't accept money from pharma. They don't like me very much. And I've been in recovery from addiction for 32 years. I just took my 32-year cake. Thank you. As a matter of fact, 34 years ago, in November of 1984, I walked out the back door of my clinic, suicidal. It was a family clinic, family practice. I was 10 patients behind. The waiting room was full. I'd been burned out for quite a while. I really stopped caring. And I was pretty sure I was going to commit suicide. And I'd been using a lot of substances. Started with alcohol, but like most doctors with addiction, I got very creative. And I called this person Doug Graham. And the reason I called Doug Graham, he was a family doctor who was compassionate and empathic, and he openly admitted that he was in recovery from addiction. And I called him up, and he kind of saved my life. I'm telling you this for a reason, because the purpose of tonight's talk, and Bill's going to expand upon it. I'm going to cover an awful lot of stuff really fast. But primary care health providers, even if you didn't have a prescription pad, even if you couldn't write a single prescription, you could do so many things with respect to addictions, engaging us in care. You heard what Andrea said, the role of the family doc. Engaging people, but also supporting us. One of the things I'll challenge you with before we get going is, when your patient has hypertension, does anybody ever put a blood pressure cuff on them as they go? I mean, you never stop doing that. Or if they have breast carcinoma, do you follow up for recurrences? Or with diabetes, do you do hemoglobin A1Cs just to follow up? Yet, over the years, I'm 32 years sober, and I always have a family doc. That's part of being in recovery, is I can't be my own doctor. How often do you think my family doctor has asked me, Ray, are you sober? Are you going to meetings? Are you doing the things that you said you were going to do? How often do you think it gets checked? Because it's a chronic disease, you know. Just think about it. I don't want to make you feel guilty about it, but I had one doctor that did it, and I think doctors don't do it because they're embarrassed. But we like it I bet you Andrea would agree, when your family doc says, how's the recovery going? I want to be able to say, well, it's kind of a rough patch, thanks. Yeah. So we're going to talk a little bit about the epidemiology, about people with addictions, because we're not all alike. We vary tremendously. We're going to talk about a thing called recovery capital, which is a game changer when it comes to addiction treatment and recovery. And we'll talk about switching from a treatment-oriented acute treatment of an acute disorder to chronic disease, chronic recovery management. And then I'm going to quickly touch on, I'm not going to steal Bill's thunder, but 10 possible roles for family docs that you can do choose what you like. You can do them all if you want. And this is just a homemade epidemiological. So 20% of the population doesn't use. They don't smoke, they don't use marijuana, alcohol, they don't use addictive drugs. That includes people like me and Andrea and some of the people at the back of the room who've used up their drink tickets. But also there are people who choose not to. You have a role to play with those. What is it? Well, it's educating, prevention, screening, because just because we don't use now doesn't mean we're not going to. The majority of the population of Canada uses substances, don't have problems. They use alcohol, and more are smoking doobies. Some have even snorted a line or two of Coke, and they don't meet the criteria: negative consequences, loss of control, compulsive use, craving of addiction. But until they put you in the grave, you're not safe, so you still have education and screening, and you have a role to play as health providers. There's a group of people, often the younger, often male, people who use in an abusive, hazardous, or harmful way. We're not sure what the percentage is. When I'm working with employers, the right way to handle them, since they don't have a disease, the right way to handle them is discipline. They don't. Hopefully, they're going to outgrow it. Unfortunately, a lot of the people who die in motor vehicle accidents, and some of them with overdoses, don't have addiction. So they don't come to us. So physicians often don't see these people. Now notice we haven't gotten to addiction yet. So we've accounted for almost 90% of the population. 6% of the population has addiction in a mild to moderate form. They get help on their own, and they don't go to treatment, and they do pretty well. As a matter of fact, the majority of people who develop a substance use disorder, even addiction, the majority will get well on their own without treatment. But they're not represented in studies because they don't consider themselves in recovery. But the evidence is pretty clear that this is true. So they either do it on themselves. I've had people who I saw in my office, and I've probably in the last 40 years treated, I don't know how many, thousands of people with addiction. But I've had people who absolutely refused to do any of my clever things. I had one woman who definitely had alcoholism, who left the office angry. I was still pretty evangelical, and I thought I knew best, and she disagreed. Who I saw several years later. She came back just to explain how wrong I was, and she was fine. She was very sharp and healthy and happy. And I said, "What'd you do?" And she said, "I joined Amway." So, which, when you think about it, it's got a lot going for it, as we see as we go through recovery process. So we did a life and recovery survey. We did an online survey of Canadians, the Canadian Centre on Substance Abuse, and we had 800 respondents, and we found out how they got sober, clean and sober. There was people with all sorts of substance use disorder. How many of them used medication-assisted treatment, what they found most effective treatment or mutual support group, and how they did. And the percentage, now this is a biased sample. These are people who self-identified and filled out an online questionnaire. What percent, how many of them do you think had a relapse after they first started recovering? It was under 50%. 51% of them stayed abstinent from the beginning of the recovery. I wasn't one of them. But by the way, in 1984, when I reached out for help, I consider that the beginning of my recovery, even though it would take me a couple more years to get sustained abstinent remission. My recovery began when I began the pursuit of this thing that I call recovery. Now, severe addiction, this is the cases that we see. These are the cases that you see in the chemical dependency or the addiction resource teams in the hospitals and in the treatment programs, and they require professional treatment. They're self-selecting because they've tried to do it on their own and they've failed. I'm not sure that I required residential treatment. I'm glad I went because it was like an intense course. It gave me a good starting point. But I probably would have made it without intensive residential. But there's lots of outpatient treatment, and then there's medication, all kinds of treatments. And as I said, we're not here to talk about that. And then the top group, or the group that are severe, they have low recovery capital. These are people with serious emotional trauma, serious psychiatric comorbidity, and it's about 0.6% of the population, and they require harm reduction. A lot of them are going to require long-term replacement therapy, but that's a small group, and even some of those will find pretty good quality recovery if they're offered the right resources. So if we're going to measure something, if addiction is a chronic condition, we need to be able to define it. What is recovery? Well, this has been, around the world, they've been attempting to answer it, and the consensus usually comes down to about 4 things. The pursuit of abstinence, and I'm going to show you at the bottom what abstinence means. Something to do with improved mental health and physical health, improved level of function in the family or in the workplace, and increased giving back, pro-social behavior, becoming a better citizen. And according to ASAM, the definition of abstinence is an intentional and consistent restraint from the pathological pursuit of reward and or relief that involves the use of substances and other behaviors. So a person can be abstinent, just like a person who's in OA can be abstinent when they're eating according to their meal plan. A person on opiate replacement therapy who meets the other criteria is certainly a person in recovery. And they're abstinent, okay? Now, this is where it gets really interesting. Recovery capital is all of those resources that I can put towards recovering from addiction. The reason that I recovered fairly easily was I had a lot going for me. You know, doctors in North America, if you're a doctor and you develop addiction, the likely, and including opiate dependence, which most of us get into opiates, we start with alcohol and move on. Our likelihood, our long-term recovery rate is over 80%. It's partly because we have all of this going for us, the benefit of privilege and education and safety and healthcare and all that stuff, but we also have ideal recovery management supports. Doctors are treated different than the rest of the population, and gradually the rest of the world's catching up because a lot of recovery management is modeled similarly to how we treat physicians. So recovery capital predicts prognosis. So it should be, when we're assessing a patient who we think has addiction or who does have addiction in our clinic or in our office, we should be keeping in the back of our mind, what are the missing pieces for their puzzle that they're going to need to fill in if they're going to stay clean and sober? Because remember, why did I use? Why did the people with addictions use? A big part of the reason we continued to use our substance was because it worked. It's how we handled a lot of uncomfortable, emotionally charged. It was a solution. So if you're just going to take away my drug, you haven't really helped me. In some ways, I'm worse off. So I need to find out what those missing pieces for my puzzle are and start working on developing them. And I've been doing that for the last 32 years, and I'm still working on it. So it predicts prognosis. Those who have very low recovery capital, the homeless, the disenfranchised, the people with severe, repetitive early childhood emotional trauma, severe psychiatric illness, and all kinds of barriers, they're going to need another form of help, another level, intensity, modality of treatment. Recovery capital is dynamic. It changes. So the whole role of treatment of addiction, the treatment of addiction serves really just to engage and stabilize, and then it's to increase recovery capital, period. That's all it does, increase recovery capital. If it doesn't do that, and if it doesn't hook people into the community to programs like at the back of this room, then shame on you, because this is a disease that goes on and on and on. Treatment only goes on for weeks, months. If it's a long treatment program, it might go on for a year. Well, that's not long enough. So the recovery journey takes longer than that. So once it's mapped out, once you, the primary care doctor, knows a person's, and by the way, I see people writing stuff down. The slides, I'm told, are going to be available, yes? Yes, they are. So if anybody wants to speak to the people at the table. Once it's mapped out, once you know what's missing, and one of my last slides shows an assessment of recovery capital screening instrument, then you can follow up and see how your patients are doing in developing recovery capital. So you can use that for recovery rechecks, which is a key part of recovery management. So it's like the missing pieces, and I won't go through all of these, but Bill will talk a bit about motivational interviewing, and Andrea talked about a lot of these things already. When Bill asked her, well, what are the things you do now to stay sober, to continue your recovery? And Andrea and the people who answered the Life in Recovery survey listed all of the things that are important now for staying sober and feeling good. It's not just not drinking and drugging. It's, if I'm not going to drink and drug, how am I going to feel good? And all of the things that are necessary. So recovery is a journey that requires some steps and stages. Early on, I have to stabilize, and you're going to help me stabilize. I was on some medication at first. As a matter of fact, I was prescribed naltrexone in 1984, of all things, long before it was popular. I didn't like it very much, but developing non-chemical coping skills, learning how to say no, changing my group. One of the most important things is my social support group. If I'm hanging around with a social support group that supports drug use, I'm going to use. That's one of the problems with offering treatment programs in the milieu of the disenfranchised in a downtown core. If you don't get people out of there, it's very difficult to change things. Learning how to set goals, learning how to manage time, learning how to have fun. Andrea talked about exercise. It took me a few years before I discovered that I had to run to feel okay, that I've got these athletic needs, and that if I was on antidepressants for years, and I was a little bit ashamed of it, because I was working a program and giving lectures about addiction and treatment and recovery, and I'm taking these antidepressants. And I started running in 2005, and a year went by, and Agnes, my wife, who I've been married to for 48 years, but at the time she said, oh, well, you're not taking your medication. I'd forgotten. They just fell off of my repertoire because I felt so much better when I was running regularly. But being a little bit addictive, I ran 8 consecutive Boston marathons and then went on to do 2 Ironmans. So this is a theoretical schema, but I want you to see it for a couple of reasons. One, recovery is a journey that takes time. That, for me, recovery began before I stopped using. And there's this immediate early jump when you have engaged me and I get hope. And I take the plunge, and we start looking really good and feeling, so quality of life, emotional quality of life, jumps immediately. And we're gradually building our levels, the blue pyramids there, our recovery capital. They're gradually building, but somewhere after the first few months, the pink cloud ends. Somewhere after that first euphoria, your patient will come in and they look awful and they're feeling terrible. They're facing the wreckage of their past. They're no longer idealistic. They're feeling terrible. And there's a temptation to say, oh my God, what's gone wrong? This person's got bipolar 2. Look at them. They're up and down like a toilet seat. Well, no, that's early recovery. That's what it looks like. And it makes a whole lot of sense. And your job is to say, good work. You know, just because you're feeling bad doesn't mean you're doing bad. Are you talking to your sponsor? Are you going to your meetings? Are you working out? Are you eating? Are you getting enough balance and rest? Because it's tough going. We try to keep them away from people who want to prescribe the medications and give them a psychiatric diagnosis at this point, because with time this will level out. But that's a universal finding somewhere between 3 months and 2 years. And people can relapse during this period of time, so they need added support. They might need to see their family doctor. But you, if you're going to serve the role as coach, expect it. When a person's been clean and sober for a while, after they've been looking really good for a while, they will start to look bad. But your job is to make sure that you are not missing something. But chances are they're right where they're supposed to be. And if you hang in, it'll get better, a lot better. Okay, so initially, the early stages are from pre-contemplative to action. In early abstinence, they're going to stabilize, complete their detox, or stabilize on medication. They've got to build a new social support network. Their family, hopefully, with your help, their family's going to get their own support program, because the family's going to have trouble. Family systems change with addiction. And if you take the person out of an addicted family that's been sick for a long time, put them in the Cedars or a treatment center, and then bring them back to that family, what's going to happen? There's only a couple things that can happen, because the hole that they left was for an addict, for practicing a really dysfunctional person. And unless the family system has changed, that's what's got to go there. So they got to go back using, or they got to leave. And so the family has to do some work too, and they'll often resist it. And that's where Al-Anon and psychoeducation and the family programs come in, and a good therapist who understands about family recovery. Maintenance is as up to the first 5 years of stabilizing, developing these new non-chemical coping skills, getting your life back, getting on a plane, and then there's long-term recovery, where you mentor, you give it back, but the growth never ends. The improvement in quality of life and recovery capital never ends. So it's not about putting people on medication for a few months or the first year or two. There's an awful lot more to do. Has anybody run this marathon? Yeah, great. It's my favorite marathon in the whole world. Well, recovery from addiction is like the marathon. It's not the 5K. And it starts with harm reduction, which is, and it may be as far as it goes. And harm reduction is essential. It's going to keep people alive, and it's going to engage them. And for some, it'll be a route into palliative care. But for many, many, it should be the engagement that begins the recovery journey. And treatment overlaps with harm reduction, and it goes on for a period of time. And it's important, but it's still short-term. Recovery looks like this. Recovery is the whole thing, and it doesn't end when treatment ends. And if there's one thing you need to take home tonight, it's treatment and recovery aren't the same thing. Recovery, so it's a chronic disorder, and we really want you, the primary care docs, to stay engaged. We really want you to be interested and ask us and ask our family members how we're doing and to provide us support. The payoff for you is that it's the most rewarding thing you'll ever do. You'll get better payoff, better outcome with this chronic disease than you do with any of the other diseases you treat. That's just a fact. So shifting to recovery-oriented systems of care. We need to go from acute treatment. Have you ever heard a treatment center saying we have this kind of success rate? Well, that means they're talking wrong, because they're talking as if it's something that you fix. Like you send the person who's having a diabetic ketoacidosis to the hospital, they get their shot of whatever and get stabilized and then sent home and it's over. No. We need to go from paternalistic to collaborative, where the patient, as soon as they're able, take responsibility. And we're doing that in medical care and chronic disease management and psychiatric care. With addiction, we need to do it too. From silos of specialized care to community care. So the recovery-oriented centers that are leading North America are delivering one-stop shopping from recovery community centers in the community, one-stop shopping. We need to have individualized care depending upon the needs, the recovery capital needs of the individual. And when a person relapses, rather than blame the patient, we need to stay engaged and find out what's missing. How does the treatment plan need to change? And that's where recovery coaches come in, and that's where good motivational enhancement, motivational interviewing techniques come in. So all doors are the right door. When a person shows up, we engage them and we hook them up with a recovery coach or a case manager who stays with them as long as they're willing. Through relapse, through whatever. One of the reasons we lose so many people is they go to St. Paul's, they come in, they go to the safe injection site, they get found on the street with an overdose, sent to St. Paul's, and then sent home, or referred to the next step, but they don't go. Somebody needs to take them. They need assertive linkage. Andrea talked about how important it was that her family doctor knew about AA. I challenge you to find out. You've got lots of patients in recovery already. Find out a few of them and find out the meetings that are around. It really helps if you know a couple of patients who are willing to serve as temporary sponsors, so that if you've got a patient who needs help, you can hook them up with each other with patient confidentiality and consent. But it's a wonderful resource. When you tell people to go to an AA meeting, they don't go. When somebody takes them, they do, and they'll keep going. So you need that assertive linkage. And then there's all kinds of recovery facilities like schools and workplaces. And I just heard about the Umbrella organization. You're fortunate in Victoria. You probably have more components of recovery-oriented care than any place in Canada, with organizations like Umbrella and choices like LifeRing, NA, and AA for those people who don't like the 12-step programs. And recovery management rechecks are a key part of any good recovery-oriented care. And guess who can do that? That's a primary care responsibility. Physician health programs. The reason that doctors have over 80% recovery rates from addiction is, first of all, we got a fulcrum. If you want to practice medicine and you got caught stealing drugs from your patients, you're going to do these things. So once a physician is engaged in care, they can't get out of it without complying. Coercion works. So contingency management works. As a matter of fact, a study looking at does mandatory treatment, how does it compare to voluntary treatment? What did you think? What do you think? Voluntary versus mandatory treatment. They work about the same. In some ways, they work better because you can keep them engaged longer. So do we end up with people mad at us because they're forced into treatment? Absolutely. But they get over it as their brain settles down, as they cognitively start to thaw out and wake up. A good, thorough assessment, biopsychosocial, looking at psychiatric, medical, recovery capital deficits. Adequate duration of their initial treatment, whether it's inpatient or outpatient. If they're bad enough to come to your attention that they need treatment, then they probably need intensive. And if you're a health professional, you get residential. They need to be kept in care for a long period of time. How long do you think we monitor physicians and nurses? Does anybody know? 2 years for the nurses. For the doctors, it's 5 to 10 years, mandatory. Why? The likelihood of relapse coming out of a treatment center is about 50%. By the time 2 years has gone by, it's down to a 20% risk rate. By 5 and 10 years, it's no higher than the general population. So when public safety is at risk, they're willing to take that risk. Prolonged medical monitoring, which is more than just p-testing. It's somebody asking them questions about, are they doing all the things on their treatment plan, all their medications, all their treatments that they agreed to and negotiate and signed on the dotted line, their relapse prevention agreement. Assertive linkage, somebody makes sure that they get going. And doctors and nurses, I don't know over here, are the caduceus groups over here for recovering health professionals? There's one, yeah. So, and it helps as a recovering doctor to be able to go to a meeting with other doctors. I just came from one in Carmel, California. There were about 100 of us there. But doctors can talk to doctors. There's a lot of shame about being an addicted doctor. And when you hear about other doctors who tell their story and are in recovery, it's a wonderfully supportive and helpful thing to do. There's a lot of things that, as a doctor, you can't talk about at your AA or NA meeting. And if in the event of relapse, there's an immediate intervention with a higher level of intensity of treatment. So it's stepped care. So this is my last teaching slide. I'll very quickly go over the 10 things that I'll challenge you to think about doing. Screen everybody. If they're over 10 years old, you should be thinking screening. And if you don't want to do it, have your MOA do it in the office. Have cage and audit questionnaires to fill out regularly in the front office. Our patients they expect us to ask. We don't ask because we're embarrassed. Engaging people, motivating them. You can motivate people like nobody else. The power that our patients give us to change their behavior. They don't care. How does the saying go? They don't care how much you know until they know how much you care. And the thing about the family doctor is they know you care. So when you express something, they can't forget it. So you have tremendous power to change people's behavior and to ask them the questions. We're ambivalent, you know. Although I may lie about my drug use and I try to hide it, part of me desperately wants you to help me. It's ambivalence. Do an assessment. And if you don't feel good about doing an assessment, get an addiction medicine doc to do. You can't do good treatment without a thorough assessment. I don't know how many patients I ended up seeing whose lives were ruined for years and years and years because nobody did a decent assessment. It was there. It's just that nobody had taken the time to do the history and the physical and the psychiatric and the review of systems and then the drug and alcohol and the pain, the psychosocial history. It takes a bit of time, but it's not rocket science. And once you've done it, it becomes real obvious what the problem is and where you need to go. But consider one of these last slides that's at the end, and that's the ARC, the Assessment of Recovery Capital. Because it's a good checklist to think in terms of what missing pieces for the puzzle might this patient have. Stabilization, you can play an important role in stabilizing the person. In the late 80s, I had a primary care medical clinic, but I was doing addiction medicine, and I was seeing people who were physiologically dependent on either benzos or alcohol or even barbiturates in those days, and some opiates. And I would do an outpatient detox on them, where I'd start seeing them on a Monday morning and see them every morning for 5 or 10 minutes and just follow them along. And it was interesting how smoothly that goes when they knew they were going to see me first thing in the morning, and what a huge part of their detox difficulty was fear. And they knew they were coming in and they'd see that it was okay. It was amazing that within 1, 2, or 3 weeks, we'd have them stabilized and ready to move to the next stage. Referring them and assertively for initial treatment, initiating or sending them for medication-assisted treatment. How many people in this room are capable of prescribing buprenorphine, have the training for Suboxone? Okay, maybe a third of you. Methadone? Okay, a few. Okay. Or recovery coaching. If you've gone, recovery coaching is not hard to do. All it is finding out negotiating a treatment plan and then just supporting them through it and seeing them regularly. Usually it's done by a paraprofessional, somebody often in recovery who's spending the time with them. But a family doctor can do an awful lot of recovery coaching just when they see them. And it's for every time you see that person who's in early recovery, you may be seeing them for postnatal visits, you may be seeing them for their hypertension, whatever, but if they've got a history of addiction, don't forget to ask and coach and support them. The family. A little bit of education and support and nudging goes an awful long way. A lot of families are going to go through grief because they don't know what they're up against. They need to go to a support group. And there's Victoria's full of good Al-Anon, good Nar-Anon, good family support programs for people who've got members with addiction. Get the family members of people with addictions to them, because sometimes it's tougher for the family members than for the recovering person, because we get lots of support. We go to our meetings, we're surrounded by people supporting us. It's sometimes pretty lonely for the family. And I talked about a sort of linkage I had a whole bevy of volunteer sponsors from AA and Al-Anon who would serve to take my patients to meetings. As a matter of fact, when I started the addiction medicine program at UBC Medical School, I used a lot of those volunteers for training for simulated patients for the students to interview. So, do I have a couple of minutes? Okay, we're gonna stop for questions. But the take-home message. Well, let's have questions. Comments or questions? We covered an awful lot of stuff. For a couple minutes, we'll answer questions, then we'll wrap up. I know, it's evening. We've got a belly full of food. No comments about? Yeah. So how do you, the family doctor, the primary care doc, engage the family? Often you'll see a family member will sometimes phone or come in and say, I got a real concern with the person. Or they'll come in with them, pulling them in by the ear. And there's a temptation just to look at the person with addiction and saying, this is the person that needs the help. But it's really, really important to set aside a little bit of time to talk to them. And you don't have to be an expert. You just have to know, that the family system that's been affected by addiction is affected. They're harmed by it, and they need help. And B, that there is help in the community. And the agencies know about it, lots of counselors know about it, the mutual support group programs have family programs. But you should know that, and you should validate it, because I don't know if anybody in this family, in this room, has had family member with addiction or an eating disorder. And I won't get a show of hands, but if you have, it's very, very disturbing. I remember my daughter developed anorexia, and I was just a wreck. And luckily, my doctor said there's a family program for who've got kids in their family with eating disorders, and we went to it. It was one of the most therapeutic things I did for years. So just be aware that that's there, and you don't have to be an expert. You yourself don't have to have the answers, or you don't have to do the education. Just be aware that it will go so far. I mean, the reason that I've been married to Agnes for 48 years, Agnes and I were married before medical school. My addiction went through some pretty awful stages in our marriage. The only reason we've got a marriage now is because Agnes got help and has a very active recovery program, and did for many years, to deal with how she was affected. So, great question. Yeah.
If you're seeing someone you don't know very well, let's say you're in a high volume sort of situation, maybe a walk-in.
Right.
There's potential for lots of opportunities. There's also potential for lots of missed opportunities. Are there any sort of quick, validated things that you can do to open the door and maybe at least make that initial connection?
Yeah, okay. So how to open the door? And great question, and we don't do it. And teaching doctor interviewing skills, it's really interesting. You can do these things so quickly. But one of the things you can do is systemically, and that is have your office, have out in the office the screening questions out there for whatever the validated screening questions you're going to use, whether it's audit, mass, and cage. The two questions, the biggest one question, and it's not validated, but I would swear by it, the biggest single question that I would ask somebody if I was concerned, is this addiction, is, has alcohol or other drugs ever caused any problems in your life? And it's not a threatening question at all, and the answer might be like, what, you mean ever? or yeah, alcohol and other drugs have ruined my life, and I never even drank and drugged, but it was because I grew up in an alcoholic home, and this is a person who needs help too. But it's us that are uncomfortable bringing it up. You can do it really quickly, and our patients expect us to. It's just that we don't. I think there's about 5 big reasons we don't do it, but one of them is that we're uncomfortable. One of the big ones. Okay, I think I'm going to wrap up. So it's really common. More than 10% of your. Oh, one more question.
My name's Don, and I'm wondering if the professionals here today feel welcome to attend an open meeting of Alcoholics Anonymous or any of the other recovery programs here today, because I have found with my experience that it's experience that I listen to. Thank you.
Good suggestion. I would say it's closer to 20% than 10% of your. We did in the early 1980s. We did a prevalence study in the hospitals. One was at Lionsgate Hospital, and the other was Royal Jubilee over here in the regular medical ward, looking for what percentage of the patients on a medical ward had had addiction, mostly undiagnosed. Do you know what the number was? Any percentage? Any guesses? 24% in both. So one bed in 4 is occupied by people with addictions. Now that's people, most of them were undiagnosed, but So in your outpatient primary care office, it's probably greater than 10%. It's probably closer to 20 than 10%. So expect it. And they look like me. They look like everybody in this room. You're not. If you're waiting till they look like an alcoholic, it's so late. You know, you're not doing your job. We're widely heterogeneous population. We come from all walks of life, and we come lots of privilege, and lots of us have a lot of recovery capital. Some of us have very little. Recovery capital are all those resources that determine what it is we need to do to recover. Treatment is just the initiation of recovery. Treatment is just the beginning. Recovery is the thing that goes for the rest of our life. And you people in this room have tremendous roles. If you choose to pick up the challenge and do it, it's very, very rewarding thing to do. And Bill will talk more about that. Thank you. If you get the slides, there's the ARC, the Assessment of Recovery Capital, and you can download it and all that stuff. And I've put in some references, so. Okay, thanks.